लंबा लंबा बाल रखता था ना, अभी भी वैसे ही है।
कौन?
वही रमाकांत।
सही है, अनकेयर्ड आदमी।
देखते हैं, मिलता है तेरे लंबा लंबा यहाँ तक का बाल।
Very good evening, sir.
Good evening, sir. How are you?
Fine, sir. Fine, sir.
Thank you, thank you. ठीक है सर, चाहिए। Okay. Anand,
Yes, sir.
now it is nearly 7 o'clock.
Okay, sir.
Right.
So, shall we start, sir?
Dr. Senthil, sir, you can start.
Yes, sir. Very good evening to one and all. Today,
Good evening, sir.
Yes,
Good
sir.
evening.
sir, today topic is approach to cardiac arrest. It's an emerging topic where every, even a lay person has to know this. And as physicians, it is our very, very important matter that we need to train and update on this latest method to prevent all the medical legal issues. Today we have a wonderful speaker, my friend, my brother, Dr. Narendra Nath Jena, who is a director and head, Institute of Emergency Medicine, Meenakshi Mission Hospital and Research Center, Madurai. And he is a president for Indian College of Emergency Medicine. And he is a past secretary for Society for Emergency Medicine India and president for Indian Society of Toxicology. And he is a regional faculty India for American Heart Association. Without wasting any time, I'm asking my speaker, Dr. Narendra, to take over.
Thank you, Dr. Senthil Kumran. Is it audible?
Yes, sir.
Oh, fantastic, fantastic. So at the outset, good evening to everyone, and I would like to thanks Association of Physician, India for the opportunity. Before I speak, I think everybody should watch this video. He is King Charles, probably everybody knows. Very recently, last week, he's 76 years old, and he is doing the CPR training program. And he's just updating his skill that he knows that this CPR training program.
Schemes created. During the visit, the monarch was put through its paces as he was challenged. 1 minute's worth of chest compressions.
Why this is very important, actually, we can see the next video. This is the real video, real scenario, what happened actually earlier. The world leaders, when they were having discussion, somebody had a cardiac arrest. This is the real videos. The video, it has written, your health is more important for your family. There will be never be anyone like you.
Portugal fainted during a speech to the country's military. Aníbal Cavaco Silva was taken ill during ceremonies for Portugal's National Day. It happened at the same time that trade unionists began
This is what happened actually when there is a sudden cardiac arrest. Across the world, when there is a sudden cardiac arrest, it is documented that it is the leading cause of death all over the world. Why this is very important? The statistic says, and the study also says, that every minute without CPR, the survival from witnessed sudden cardiac arrest decreases 7% to 10%. By example, if you are not, there is a patient or someone we know that he is having suddenly collapsed or having sudden cardiac arrest. And if we are not doing anything for 1 minute, 2 minutes, 3 minutes, or 5 minutes. So 5 minutes means 50% survival rate is decreases. So that means if we are not doing anything after the sudden cardiac arrest, most of the time the patients they die. So, but the science also says if we are doing CPR, cardiopulmonary resuscitation and defibrillation within 3 to 5 minutes of sudden cardiac arrest, then survival rate is as high as close to 75%, 50 to 75%. For example, if you are doing CPR and defibrillation at a time or early as possible, then the survival rate out of 10, we can probably 5 to 7 patients can be survived. So this statistic says, even if the best country healthcare is concerned, 350,000 people die before reaching to the hospital in US. And majority of people, they die because most of the time the defibrillation or the CPR has not been attempted or not done. Now you can see Indian statistics, though we don't have registry of sudden cardiac arrest, but there are the Lancet Commission to reduce the global burden of sudden cardiac death. The study they found that 5 to 6 lakhs people are dying due to sudden cardiac deaths in India. So if you see this chart, 50% patients they die due to sudden cardiac arrest in India, apart from other diseases. So this is what happened in India inside the parliament. Probably some of the attenders have watched this video. So he is former Minister E. Ahmad, who suffered sudden cardiac arrest inside the parliament, which we say the most safest place in our country. There, after his sudden collapsed, they have taken to the Ram Manohar Loya Hospital, and he was declared dead after reaching to the hospital there in the emergency. So that shows when there is a sudden cardiac arrest or sudden collapsed someone, the facilities what we had or what we have at present is not enough. Most important thing is defibrillation and training and awareness about the sudden cardiac arrest. According to the National Crime Report in India, so the number of deaths due to sudden cardiac arrest increases by close to 12 to 13% in 2022 compared to 2021. Even young people are susceptible to sudden cardiac arrest and sudden cardiac death. So this is what we have seen, that most of the newspaper, we have cardiologists, emergency doctors, critical care physicians, they're talking about sudden cardiac arrest, then the CPR training program. This is what happened actually. Even the singers, he is a singer Puneet. We know about him that it was his last live show in Calcutta, and he died due to sudden cardiac arrest. Apart from that, if you see the statistics, big shots like cardiologist, Paperfry CEO, even the Chandrayaan-3, the scientist, they have died due to heart attack and followed by sudden cardiac arrest. Now imagine that we are traveling by flight and the Indian pilot, that pilot having heart attack followed by cardiac arrest, then what will happen? So this is how happening actually most of the time. Even not only the experienced people, even the young people are susceptible to sudden cardiac arrest. This is the statistics says that 1 out of 40,000 to 80,000 athletics also can have suffered sudden cardiac arrest. So what is the cause of the sudden cardiac arrest? If you see the literature can say that most of the time because of due to cardiovascular diseases or hypertrophic cardiomyopathy or other cardiomyopathy, genetic heart abnormalities, myocarditis, blunt trauma to the heart or chest, drug overdose, and of course, most of the papers also shows that COVID-19 also can have a region to sudden cardiac arrest, MI and death. So if we talk about hypertrophic cardiomyopathy, it is estimated that out of 1,000, 2 young adults can have enlarged heart muscles. Among those who are diagnosed with hypertrophic cardiomyopathy, around 1% experience sudden cardiac death each year. So again, this can be myopathies can be dilated cardiomyopathy or left ventricular non-compaction cardiomyopathy or ARVC. Genetical heart abnormalities can be coronary artery abnormalities or genetic valve abnormalities, including mitral valve prolapse or structural differences in aorta. Apart from that, there may be, if ECG already found some type of long QT syndrome or WPW syndromes or Brugada syndromes are very much susceptible due to sudden cardiac death. If you see myocarditis, one of the very important cause or common cause is virus, inflammatory diseases, chemicals, certain medications, radiation therapy also can cause myocarditis, and this can cause also sudden cardiac death. Apart from that, we know that acute cardiovascular diseases, particularly CAD, heart failure, diabetic, ventricular arrhythmias, risk factor like smoking, obesity, alcohol, sedentary lifestyles are also susceptible to sudden cardiac arrest. Blunt trauma, again, one of the cause of sudden cardiac arrest. Drug overdose, particularly opioids, tobacco, and which drug causes QT prolongations are also can cause sudden cardiac arrest. There are so many papers actually after COVID-19. We have seen that COVID also one risk factor for sudden cardiac arrest due to lack of oxygen, myocarditis, stress cardiomyopathy. We have seen so many patients, particularly young patients, are now admitted to the hospital due to MI and stress cardiomyopathy, pulmonary embolism. So these are the basic cause of sudden cardiac arrest or MI. If MI is not treated early or quickly or not diagnosed, then these patients can have sudden cardiac arrest. So these are the papers already we have seen that sudden cardiac arrest due to COVID. So what are we supposed to do actually when there is a sudden cardiac arrest in front of us? Or what are we supposed to do? So most important thing that we have to do CPR. And we know CPR is cardiopulmonary resuscitation. So what happens when there is a sudden cardiac arrest? As we know, there are basically 3 important signs or symptoms, signs. So one, patient will be suddenly, when there is a heart stops, then there is a blood circulation will be stopped. That means there will be no pulse. Once there is no pulse, then definitely there is no blood circulation. And this blood circulation, particularly to the most important organs, including the brain. And once the brain is not getting blood, that means there is a deprivation of oxygen. So oxygen is not getting, brain to the neurons. So then patients start losing his consciousness. Once the consciousness is patient become unconscious, then definitely patient will fell down. Once patient fell down, then second important, all the muscles of the body suddenly patients loosen. The muscles is relax. Once relax, including the tongue will fall back. Once the tongue will fall back, then definitely there will be obstruction to the airway. So basically, three important signs of one sudden cardiac arrest. One is there will be no pulse. Second will be patient will be unconscious. Third will be definitely there will be no breathing or gasping or agonal breathing. So what we supposed to do then that particular time definitely required CPR, cardiopulmonary resuscitation. It is most easiest but most important when patients suffer cardiac arrest. So in emergency, most of the time, as I said, if 1 minute we are not doing CPR and defibrillation, then approximately 10% mortality can be increased. So that's most important. Even if there is just so many training program, at present, the statistics says that less than 40% only they received CPR and around close to over 10% received AED after the sudden cardiac arrest. That's why it is so important that we should learn about CPR and AED, automatic external defibrillator, or how to do it give to the shock to the patient. This is how the science says. If you are not doing CPR or delayed defibrillation, after certain times, particularly 6 to 10 minutes, there will be straight line. Means ECG will be straight line. If you are not doing defibrillation, early CPR and delayed defibrillation, even delayed defibrillation patient chances of survival also minimize. But if you can see, if within 3 to 4 to 5 minutes, if you are doing CPR and defibrillation, chances of survival are mostly 60 to 70%. That is why most of the time the BLS training program is required, and basically we should train and we should teach others so that sometimes if something happen to us, somebody can train to save us our life. So American Heart Association, who is doing research most of the countries regarding the science, resuscitation science, and every 5 years they do research and they update their guidelines. So last time they have their guidelines has been changed from 15th to 20. So what I'm going to talk about, this is the recent guidelines and what the American Heart Association they have updated in the resuscitation or sudden cardiac arrest. This you can see the 2015 guidelines where the primary providers, they will assess and they will start the CPR and the defibrillation, and after that the patient will shift to the hospital. Same simultaneously, but chain of survival, which they have updated in 2020, where they documented that if the sudden cardiac arrest signs will be early recognition and prevention. Apart from that, if we activate the emergency system or response, and if you give high quality CPR, including defibrillation, post cardiac arrest care, recovery is high. That is what they say that this is a chain of survival, everything interlinked. So starting from the early recognition, prevention to the recovery, that's very important. Most of the time we have seen, including US, that the chances of survival from in-hospital sudden cardiac arrest are more than outside hospital cardiac arrest. So in hospital or outside hospital cardiac arrest, the treatment is mostly same. that we have to recognize the signs of sudden cardiac arrest and start CPR. So before starting CPR, we should know the 5-finger techniques. 5-finger techniques, what we supposed to do, whether the scene is safety, check response, check pulse, start call for activated the cord blue, check pulse and start CPR. So what we supposed to do, immediate recognition of sudden cardiac arrest. So that is what I told, check responsiveness, whether patient is responding or not responding. And if there is an absence of normal breathing or no breathing or gasping, so then we have to check the pulse, whether pulse, particularly the cardiac carotid pulse, and breathe simultaneously. And if not, so then we have to activate the emergency response system. Then once we talk to the emergency or the ambulance, we have to utilize this 5W, whom to call, who you are, where you are, what is an emergency, and what you want. Start chest compression without wasting more time. So that is how CPR is all about, or basic life support is all about. Where to do the chest compression? Of course, it will require certain training, simple training. I don't think it is a very big procedures, but if you do properly, effectively, most of the time, in my experience, most of the time these patients survive. And where we should do, it's a mid-sternum, the line joining two nipples line. Our hands will be interlinked and our elbow will be straight. The force should come from the shoulder, and vertically we should do the basic, like this type of this video, 100 to 120 compression per minute, means every 60 seconds, at least 2 inches. 2 inches means 5 centimeter depths, and we have to allow complete recoil of the chest. So that is how it is very important. And this is called high quality CPR, high quality cardiopulmonary resuscitation. So as I said, very important, chest compression of adequate rate, at least 100 to 120 per minute. So compression should be depth, it will be at least 5 centimeter. In adult, not more than 6 centimeter. Complete chest recoil after each compression, minimizing interruption in chest compression. That's so important, because most of the time we have seen, we do for couple of 10 to 15 second compression, then we start checking the pulse. We should not do like that. If we'll do like that, most of the time we lose the patient. So important thing, minimum for 2 minutes we have to do CPR, not less than that. Avoid excess ventilation. In multiple people are available, then we can rotate every 2 minutes after doing the CPR. So adult, we can do 30:2, 30 compression, 2 ventilation. If there is 2 people are there, 30 compression somebody can do and 2 ventilation the other people can do it. In pediatrics, 30:2, and if there is 2 people are there, 15:2, means 15 compression, 2 ventilation. Infant also mostly same. That is how the hand techniques and placement of adult, children's and infants should be when we are doing CPR. What we do in common mistakes when we are doing CPR, we do too shallow chest compression or too slow, or sometimes we do so fast. So, and if you are continuing doing for more time, then definitely the person will be having fatigue. So definitely we should not do excess ventilation or so fast compression. That's the most important thing. And we should only stop to check the pulse only after 2 minutes. There are certain risks and complications of CPR. It's a very simple complication sometimes, but if you do properly, the complications and risks are very minimal. And if you are not doing left or right side, there are chance of fracture ribs or pneumothorax are possible. But most of the time, CPR is most important. Then we're thinking about this risk factor. So how ventilation we supposed to do? That is called rescue breaths by mouth to mouth or bag mask ventilation. We have to deliver each rescue breath over 1 minute. So one breath, it's supposed to be every 6 seconds. So 1 minute, we should do approximately 10 breaths. And compression and ventilation, it should be 30:2. That is the most important thing. And with this ventilation, we can see that the visible chest rise. Then we can know that, yes, we are ventilating properly and adequately. Most of the time, when we are talking about defibrillation, so defibrillation is particularly, it is available inside the hospital, emergency department or ICU. But AED, it is called automatic external defibrillator. Most of us we don't have experience with AED, but it's a very simple machine and automatic machine having 2 pads, and we have to just, I have seen most of now people, they are keeping in their car, their home, if there is a elderly people are able, is there. So it can save life. We have seen. And it is a very simple, very easy machine, 2 pads, we can just fix it. And once the patient is, if there is a patient is unconscious or having sudden cardiac arrest, we can fix the pedals and we can switch on. The machine can recognize that this, whether it is a defibrillator, means shock to be given or not to be given. So the machine can analyze itself and deliver shock. So this is American Heart Association, the schematic chart. Then they say that if patient is having sudden cardiac arrest, we have to do CPR and attach to the monitor. And if defibrillator or AED is available, we have to give as early as possible shock, and we have to do 30:2 compression. And after 2 minutes, we have to, check for the pulse. So this is 2020 BLS summary that even the lay person should start CPR. So if patient is having sudden cardiac arrest or sudden faint, we should check the pulse and carotid pulse and check for breathing. If it is not there, we should call for help and start CPR. This is what the awareness program everybody should learn and everybody should be taught about this. So this is the schematic picture, and most of the hospitals we have placed in the emergency and ICU, and everybody should know when to do, how to do AED, automatic external defibrillator. When to terminate basic life support. If patient is unconscious, we have done CPR, we have done defibrillation, but how much time we should do CPR? So particularly basic life support termination or should not be attempted when arrest is not witnessed or bystander not done CPR, or there is no return of spontaneous circulation before transport, or not shock is not delivered. Most of the time, CPR and defibrillation or AED should be attempted when at least when there is a patient is unconscious in front of you, or somebody is brought to the emergency department or hospital. At least we should check the pulse and see the with the pedals we can check the monitor ECG, what type of rhythms. So cardiac arrest, if you see that most of the time, the sudden cardiac arrest happens with whether it can be divided into 2 types. One is whether it is a shockable rhythm or it is a non-shockable rhythm. Shockable rhythm means whether we should give shock, or non-shockable rhythm, whether we should not give shock. Particularly when there is a shockable rhythm, that is called ventricular fibrillation or pulseless ventricular tachycardia. Non-shockable rhythm, it is asystole or pulseless electrical activity. If you see the recent guidelines in asystole or pulseless electrical activities, Earlier, we used to give atropine, but last guidelines, they have changed to adrenaline, epinephrine, as early as possible. After that, CPR, CPR to be given 2 minutes. Then again, we have to give adrenaline and CPR. Whereas when ventricular fibrillation and ventricular tachycardia, we have to, if there is some type of rhythm is there or pulseless ventricular tachycardia is there, then we have to give as early as possible, give shock and CPR. And we have to think about the reversible cause of cardiac arrest, particularly 5H and 5T. I will describe later. So this is what shockable rhythm, that we have to check the pedals. Through the pedals, we can see the rhythms. This is defibrillation. We have to give the defibrillation. As I said, cardiac arrest, shockable rhythm, non-shockable rhythm. I will show you. So this is shockable rhythm. This is called, first ECG called ventricular fibrillation. And second is pulseless ventricular tachycardia. So what monitors most of the time, we will see on this type of something, there is, this is the first ECG shows ventricular fibrillation. Second, ventricular tachycardia can be divided into two, monomorphic and polymorphic. Now you can see the heart, when the ventricular fibrillation, the heart before, straight line, the heart fibrillate muscles. So then it can be stopped within few seconds. But if in this time, if we do defibrillation, then this patient can be, they change to ventricular fibrillation to asystole if you give ventricular shock as early as possible. So this is how ventricular fibrillation rhythms, and ventricular rhythms, there will be no PR interval, as we know. QR complex will be wide and aberrant. The rhythm is irregularly irregular, you can see, and there will be, most important, there will be no pulse. Patient will be not breathing and gasping. And required here, as I said, that patient required defibrillation if there is a biphagic, of course 200 joules, monophagic 360 joules, and of course after giving shock, we have to give epinephrine, amiodarone, and supportive drugs that required. And if we are not doing anything, if we are not defibrillating, not doing CPR, not doing any pharmacotherapy, then mostly within few seconds to minutes, the patient will be asystole and death. This is called ventricular tachycardia. This is called pulseless ventricular tachycardia, where patient required defibrillation. And as we know, mostly the ventricular tachycardia, mostly 100 to 200 beats per minute. And of course, here it will be pulseless, means there will be no pulse. Again, patient will be no breathing or gasping. The rhythm will be here regular, but it can change to different rhythms. And there will be no PR interval. QR complex will be wide and aberrant. And of course, same thing, we have to monophagic 360, biphagic 200 joules. Again, we have to give shock, epinephrine, amiodarone, and supportive drugs. If we are not doing anything in ventricular tachycardia, pulseless ventricular tachycardia, for example, if you are not giving shock, not giving any CPR, not giving any drugs, then again, this patient will again go to ventricular fibrillation. Again, then after that pulseless electrical activity or asystole, and patient will die within few seconds. So these are ventricular fibrillation and pulseless ventricular tachycardia. This is shockable rhythm. But asystole and pulseless electrical activity are non-shockable rhythm. That means we don't have to give shock here. So when this is called in monitor, when we see in the monitor is a straight line, then this is, of course, it is a asystole. So asystole, we have to, the flat line protocol is there. For example, we have to check the ECG lead, whether it is really true asystole or not. We can gain the ECG in the patient's monitor. And of course, the patient will be clinically, there will be no pulse, no breathing, there will be no electrical activity. Sometimes people's already, dilated, and there is no shock is advised. If you are attempting, then we can give epinephrine and of course CPR, epinephrine CPR, and we can find out, we'll do the CPR and after some time, probably we can find out the reversible cause of cardiac arrest. This is just looks like normal sinus rhythm. There will be P wave, QRS complex, T, all is there, but here it is no pulse. So that is how it is called pulseless electrical activity. And here patient will be no having pulse or no patient is not breathing. It looks like an organized rhythm, but it is not. There will be no pulse. It is, if it is there, so patient required again epinephrine, CPR, and if you are not doing, again this patient can go to ventricular fibrillation. So when we should not or we should stop our resuscitation, again, if there is arrest is not witnessed, no bystander CPR has been not attempted, or after doing CPR, there is no return of spontaneous circulation or no shock is delivered before transport. So that's how it's so important that we have to give defibrillation, and CPR is so important. So why this sudden cardiac arrest happens? So mostly this is 5H and 5T. So 5H means hypoxia. Maybe there is due to certain region, patient can be saturation may be low, or maybe severe pneumonia, maybe some type of breathing problems, or second H is hypovolemia. Maybe patient is in shock due to different, so many causes, or patient can be having acidosis. Patient, another important thing is hypo or hyperkalemia. If patient is having potassium is less than 3 or more than 5.5, patient can have sudden cardiac arrest, or patient can have hypothermia. So this is 5H. 5T, certain patient can have, of course, poisoning, cardiac tamponade, tension pneumothorax, pulmonary embolism, or coronary thrombus. Patient can have this 5H and 5T, and these are 5H and 5T. They say it is a treatable cause of sudden cardiac arrest. If you treat, these patients can be survived. So basically, if you think if there is a sudden cardiac arrest, we supposed to do CPR first, and quickly, if outside the hospital, then we can think about AED, automatic external defibrillator. Inside the hospital, we should have a code blue and CPR and defibrillation, and of course, adrenaline, amiodarone, or whatever the drug therapies are there, we should do it. And of course, there are chance of survival is more when we are doing systematic approach of CPR, AED, and pharmacotherapy. And after ROC obtained, there is a post-cardiac arrest care, what American Heart Association or resuscitation is, is asking to follow up or admitting these patients to the ICU, where we can we can assess these patients. We can make this target temperature management, and of course, we can follow up their vitals. The target temperature, we should keep 32 to 36 degree centigrade for 24 hours, and slowly we have to maintain their normocapnia, euglycemia, and of course, we have to provide continuous or intermittent EEG monitoring, which is most important for post cardiac arrest care. So when we talk about this basic life support or advanced cardiac life support, we have to think about this 6E, most important: early recognition. Patients, so many patients, those patients, we can think about that. ICU patient is different. ICU patient, we know that these patients are very sick, and they also can, if patient is sepsis or patient is hypotension and required so many inotropes, these patients are, this 5H and 5T patients are susceptible to have a sudden cardiac arrest. So the basically early recognition is the key. early assessment is another key. So before patient is going to cardiac arrest, we should address this. That's the most important. If patient is susceptible to cardiac arrest or sudden cardiac arrest, our team has to be trained properly so that they will quickly assess, and if there is no breathing or patient is gasping or there is no pulse, we should do CPR. We should not delay CPR. 1 minute delay, 10% reduce the mortality. 5 minutes delay, nobody can save these patients. And most of the patient, even inside the hospital, most of the patient after sudden cardiac arrest, even in ICU, patient die because delay in CPR. In my experience, last 20 to 25 years, since if you do early CPR, then most of the time chances are revival is more. And early defibrillation, early advanced cardiac life support, particularly put the tube, assess, do the pharmacotherapy, do CPR continuously for at least for a few minutes, 2 minutes to 4 minutes, 6 minutes, and most of the time these patients come back. And of course, we early patient recovery, 1 minute's count for 7% of prognosis. That is what the study says. So recommended approach of multinodal neuroprognostic of adult patients after cardiac arrest. As I said, we have to make a clinical management. Certain patients require imaging, electrophysiology, clinical examination, biomarker, certain things. But mostly we do targeted temperature management. That is what first 24 hours, 32 degree to 36 degrees. And after that, slowly rewarming. These patients should be, and every hour patient return to normotherapy, and that it will take 12 to 16 hours rewarming. And after that normothermia is achieved, the goal therapy should be maintain temperature and 37 degrees centigrade to avoid hyperthermia. So if the study says bystander CPR training program is very poor and training programs should be given, even gender related barriers are there. So they says to improve the bystander CPR, we should promote and give more training program about CPR so that there will be chances of survival will be more. And of course, it is not one-man show. It required many peoples. It required a team, in particularly when there is advanced cardiac life support will be addressed. And somebody has to do CPR, somebody has to do defibrillation, somebody has to give the drugs. And required, it is a team. And ACLS, this is called ACLS, but basic life support is when we can do CPR quickly, we can know the sign and symptom of sudden cardiac arrest, call quickly to the nearest ambulance if it is outside the hospital or at a home. And we have to do continuously. We should not leave CPR, we should do CPR. Nowadays, technology is very advanced, as we know. That's the first thing as a healthcare providers, we should educate not only ourselves, we have to educate our family members so that they will know what is the sign and symptoms of sudden cardiac arrest. And of course, these are the 6 E: education, engineering, particularly technology, enforcement, compulsory. Everybody should learn CPR. Now, for example, NABH is one type of when we are going for accreditation that everybody should, including the driver, should know about CPR. Economic incentive and emergency response. It should be the 6E, should be such a way so that mortality can be decreases. So new technology, we should utilize the new technology now. Nowadays, the smartphones, smart watches are available. When before having, there is a myocardial infarction or MI or some arrhythmia, the ECG can, we can get the, if there is an abnormal heart rate, we can, it can be visible in the watch, or this this can be also transmitted to your doctors or your relatives. If there is a patient, we can know exactly before something happens. This technology can be assessed, and it can give a red signal. So it is very good that there are a lot of studies has been done, particularly genetics test, who will going to be susceptible for the sudden cardiac arrest. And of course, there are so many studies has been done, particularly for the South Asians, Indian. We are genetically very susceptible to having more elevated risk, particularly heart and metabolic diseases. So we should be more careful regarding sudden cardiac arrest. And as we have metabolic problems, more diabetic, more hypertension, untreated hypertension. So there are chance of sudden cardiac arrest are more in India. And so that basic life support is base of when we are talking about sudden cardiac arrest. Everybody should learn basic life support. Apart from that, we should remember that high quality CPR and early defibrillation can save life. And we should keep in mind that BLS plus ADD is equal to ACLS. ADD means adrenaline, airway management, defibrillation, and drugs. These three aid: basic life support and aid is ACLS. And most of the time, unstable patients are always susceptible to have sudden cardiac arrest. Apart from that, now we know that young people also going because of stress, and there are so many causes why these people are getting sudden cardiac arrest. And if it is not addressed, then definitely we may lose lives, because in sudden cardiac arrest, time is life. And we know this gentleman. I always put in my slide his photo, and he is Mr. Rakesh Janwalia. When he was in the hospital, he was saying that I have done wonderful investment, but my worst investment has been, it is my health. And most of the time, we doctors, we neglect our health. Apart from few percentage of doctors, they regularly walk, they regularly do their blood test, they regularly do exercises, they take their food properly. But most of the time, we doctors, and we can see one Gujarat cardiologist, he's 41 years old, and he has done many cardiac surgery, but still he died due to sudden cardiac arrest. So among young people, we have seen so many in emergency, in ICU, so many young people coming 20, 25 years having MI, stroke, because of their lifestyles disorders. And we should be very careful, and we should advise properly. Particularly, as I say, we should be active, and we should control our cholesterol. We should eat healthy, lose weight, manage our blood pressure, reduce our blood sugar. Smoking, alcohol is very, we know the consequence of all this. That's what American Heart Association, they promote life simple 7. These are the 7, 7 things that we should look after. And we know that life is precious, make it healthy. And thank you for your attention. So this sudden cardiac arrest or basic life support or advanced cardiac life support is a bridge between the arrest and recovery. So if we know certain things, and definitely, and we can teach our people, definitely someday we can save lives. And if something will happen to us, someone, those who trained, they can save our lives. So thank you so much.
Thank you, Naren, for a very wonderful session. Any doubts? What about DNR order? How to take up? Okay. DNR order, now the government has approved and the High Supreme Court is also given a permission. It's a palliative therapy. If it is a patient's wish, if the patient or patient's immediate relative doesn't want to resuscitate the patient, you document it clearly, get a witness, and then you can go ahead. There is no legal binding. What is the duration of cardiac arrest prior to CPR impact outcome? So when to stop cardiac arrest? So both questions are same. So what we can do is, once the patient is getting return of circulation back, or the patient is improving, or you see that the patient is not going to improve because of very worst trauma, and you become tired, then you can stop the CPR.
We should do CPR at least for 30 minutes. That is the protocol. And all the basic life support and advanced cardiac life support should be attempted when there is a sudden cardiac arrest.
Any other questions? Post cardiac arrest care. So once the patient is resuscitated and return of spontaneous circulation is obtained, patient has to continue the ventilatory support, hemodynamics, and the other important thing is you have to go for a target temperature control management. You have to induce hypothermia. So by inducing the hypothermia, we can go for a reduce the other metabolic needs, okay, so that the patient's outcome can be good. So you have to wait for 72 hours to know whether the patient is neurologically improving or not. So we have to wait and watch.
Sir, one question, sir, about troponin I versus troponin T. Is it always trop I that is necessary, or do we also have to order
So
trop
there
T?
is a recent paper in NEJM. It's comparing head to tail of trop I and trop T, and they didn't find any significant difference. Whichever it is available, you can use it. In 2012, I remember that there was a paper saying that trop I is better than trop T, but not exactly now. So anything we can do, whichever it is available, we can do that.
Thank you, sir.
How long antiplatelet? Yes, following PCA. Sir, actually, we have to continue dual antiplatelet and anticoagulant minimum 6 months. If no other questions, we'll wind off. Any other questions, please? Thank you. Thank you, Naren.
Thank you. Thank you so much.
Good night to all. Bye.